really our primary goal is not to do surgery. Pretty much anytime somebody walks in the office. Some things have clear indications, some things you can try to manage or work with, and some things just flat don't need surgery. This is somebody who had this deformity and just didn't have surgery when she was 13 or 14 or 15. I think her curve was somewhere in the 50 range. Her main curve was in the thoracic spine, and then she had a reasonably large compensatory curve in the lower thoracolumbar spine, but it was very mobile, and so we didn't address that curve. We just addressed the curve that was stiff, and then the mobile spine should accommodate back to that. So if we were to address her whole curve, it would be T4 to L4 or something like that. But again, we can spare the lower lumbar spine and I think help with long term. So I've seen her back, and you can see how she has the compensatory lower curve, and that her spine overall is much straighter. But if we'd have instrumented more levels, maybe cosmetically you didn't straighten everything straight as an arrow, functionally they're much better off for that. She had a lot of rotation in her curve, and somewhat imbalanced regionally. So even though her overall alignment top to bottom, if you just looked at her head and looked at her pelvis, it was looked pretty well lined up. Within that area of the curve, it was fairly marked, and a lot of rotation or twisting. So our goals were just to improve her alignment, balance her spine, and minimize the number of levels we've used to mitigate adjacent segment problems, and really help her keep maintain her function. The left side is the correction side, so we put out what we would call a high density of implants on that side. Pretty much try and get usually screws into the pedicle screws into the vertebra at each level, and if you have like segmental fixation like that with high density, you can really influence the curve correction. And then on the opposite side, we just put in a much lower density of implants just to kind of help hold. I think with modern day, what modern day implants have done really is to allow you to fuse fewer levels. So that's good. The more levels you can spare and still correct the deformity and maintain it, the better they'll be long term. And I think, in general, from my point of view, the more levels you can spare below, so in the lumbar spine, the much better off you are, and probably the less likely you are to develop adjacent segment problems. So, you can imagine if you fuse the spine, that's going to place stress on other areas of the spine. And the lower you go, towards the tailbone or sacrum, the more localized stress and the more you're going to affect mechanics. If you can limit, most of the fusion to just the rib cage area or thoracic spine, that really has a lot less influence on the overall mechanics of the spine. We do have a navigation system. Take some sort of CT scan during surgery, so a three-dimensional study. The machine then records, and then the tools you use during surgery are navigated or tracked, so you can watch on a screen and see where your trajectory is. You have to know how to do open surgery in order to be a good surgeon with navigation. And the navigation just helps ensure, especially in those where you have a really tight tolerance, that you're in the right direction. I think, it also, in deformity, because things are twisted and aimed in odd directions, it's just more challenging anyway than, just a straight spine. So it does, I think it allows you to instrument it more safely. You have an idea of what the spine should look like just based on normal anatomy, and so generally you bend the rod to the position you want the spine to be, not to the position she's in. Part of the surgery is doing facetectomies, or basically partially removing all the joints so you loosen everything up. I do that with an osteotome or like a chisel, but some people use other ultrasonic type cutting devices or other devices. But you need to loosen up all the joints. So essentially you tear down the spine and then rebuild it again. but because it's loose and mobile, and especially in younger patients, you can get it to move to the rod and get it straighter. You know, it went from plus or minus 50, whatever it was, to probably, you know, the 10, 15 degree range. So that's, you know, it's not perfectly straight, but it's good. You can still see a little rotational deformity as well. You know, that worked well. And then the last part is just the actual fusion process, because in the end, the implant's just there to hold the position like an internal brace, but you need to get all of those bones essentially to grow together, because screws won't hold up for 80 years, you know, in a 20-year-old. So all that bone needs to grow together. So we prepare the bone by essentially injuring the bone, or decorticating is the fancy term we use, with either the osteotomes or burrs, so that it provides a surface for new bone growth. And then we recycle her bone from all of the decorticating stuff we do, and we use allograft bone as well to supplement that or expand that. What MUSC is unique for is really the complex deformity. So hers I would not consider complex, you know, and some of certainly some of the pediatric cases can get much more complex, especially those that are due to more congenital problems or neuromuscular problems. And then in the adult, you know, people have had prior surgery, have had prior decompressions, need revision decompressions, along with, you know, procedures like osteotomies, which are really, you know, cutting out wedges out of fused areas and reshaping the spine totally, doing front and back surgery from the side and the back. They're big surgeries. You know, you need a good anesthesia team, you need a good ICU team, you need a good blood bank. And there are a lot of, you know, components that go into those. So I think the more complex the deformity and the problem becomes, I think the more MUSC stands out as a center of excellence.